Thank you, ladies and gentlemen. Welcome to Mumbai. Those of you who you are from Mumbai, please know that we are outsiders. We actually have no right to welcome you. You should be welcoming us. Elets Technomedia, led by Mr. Ravi, our good friend for many decades, has been doing phenomenal work, not just in healthcare. So my first challenge would be to reduce this comprehensive man into the vision we have in our hospitals. Because he deals with waste management, financial services, many things like banking, entrepreneurship. And as a trained hospital administrator myself, healthcare is the funniest business in the town. And I will tell you why I am saying so. Just one example. There is no business that can happen without logistics, right? Agreed with me? No business that can happen with logistics, without logistics. We pay for logistics only when we consume a product. Is that statement right? It has to come to us, we have to consume, hence we are paying for logistics. In all businesses, from railways to food packaging to Xerox machine, everything. Now look at healthcare. Imagine an orthopedic surgery OT. 20 implants come to you in a tray. The surgeon uses only one implant because nobody knows which implant size will fit the patient. The rest of the implant cash flows are stuck. Somebody has paid for logistics, cost of which is included in the implant that we are using. And the 19 implant screws plates which we don't use are sent back to the supplier. We don't consume it. The only business where we pay for logistics without consuming. Second example. And that's why AI is important, which is the theme of this conference. Second example. In any industry, including a train ride, we expect train to reach on time. Right? Flights to reach on time. If somebody tells you Mumbai to Delhi flight will cost 10,000 rupees because it takes 2 hours, but you can take a slower flight, reach in 5 hours. Generally, when you are paying for a slower flight, say a drop journey in Ahmedabad or drop journey in Nagpur, you will pay lesser because it's taking you slower, right? In any business, if your service reaches slower, you pay less. Yes or no? Imagine a radioisotope. Shelf life of 6.5 hours. From BARC or wherever cyclotron is, it has to reach a PET CT scan center in a cancer hospital. You pay for an activity, say 30,000 rupees for 100 curies of activity, radioisotope activity. But if the distance is far, it has to reach slower. You load more activity because the shelf life is dropping, and so you pay more for slower delivery. Just the opposite of the rest of the world. I can go on with these examples. I do this within the government and I do this in private sector just to drive home the point that we are a crazy lot. We are a crazy lot because we don't know when our duty hours will end. Many of you are hospital administrators. I'm sure your family knows that there is not a fixed time for you to come home. Unlike IT, unlike transportation, where your shift can end, your one patient can hold you as hospital administrator, although you might be managing 1,000 beds. Your one patient can hold you. So we are people who live in a very complicated industry. Extremely, and with due respect, every sector is complicated. Unfortunately for us, complication is irreversible. Life is gone. In every other sector, it is a financial loss, can be recovered, sometimes even backed by insurance. In our sector, it is gone, you pay for it. In other ways, whether loss of reputation or loss of business or legal suit, but the loss is irreversible most of the times. And therefore, we not only live under very peculiar circumstances that are not common with other industry, our loss is also perhaps the only industry where loss is irreversible. Yet, we wear a nice tie, a nice dress, come to a conference with smile as if everything is fine. That is why medical professionals are angels. If you see angels, they are always smiling with feathers, with wings. And you see healthcare, whether it is a nurse or a ward boy or a hospital administrator or a director or a chief operating officer, many of my friends from various hospitals, they will come in their best of attires as if everything is fine, and at the back of their head, everything complicated is going on. The reason we are here is to tell you that in the glamorous world of AI and deep learning, many products, many services will come to you. Most of them don't understand the baggage we manage. They don't. They come with a very beautiful presentation, and unless we have the right basic understanding, we need not become super coders of quantum computing, but unless we have basic understanding of where it fits in into our game, it may be useless, sometimes even backfire. So we are here, as he rightly mentioned, is to gain a collective understanding of applying modern tools in our complicated family. Like a fantastic video game in a family of 10 children. You know, sometimes you have to rational the game, sometimes you have to see that the game is not overplayed, sometimes you have to ensure the game is not betted upon. Everything we have to do, and this understanding is important. So let me tell you just 4 simple things. I'll keep it short and sweet. I have this unique ability to make you sleep in 10 minutes without medicine. So I am a competitor of alprazolam. So if any of you think I am getting bored, please know that I am making myself successful. And if you want me to fail, just raise your hand and ask me a question. Otherwise, I am extremely capable to make you all fall asleep in no time. Now, 4 little things. Large number of interventions are coming into healthcare from outside healthcare. Large number of interventions, particularly around AI. Now, when any innovation, intervention, business proposal comes to you, there are 4 simple steps we follow which helps us not only take the right call, but also arrive at the right cost. And I'll tell you those 4 simple interventions. 1, you know, it's in our segment, and I'm sure, I think most of you work in hospitals. Yes, some work, some are from hospitals. In our sector, even nurses who go into operation theater are supposed to remove their marriage rings because it can carry infection, right? We don't use ribbons, no long hair. Even if hair is there, we put a gown. These are practices that our, like chef in the restaurant, he wears that cap so that hair does not fall, right? Because that impurifies the product he is making, right? So in our hospital sector, we have this practice that people will wear minimal jewelry, cosmetic during duty hours. Sometimes we are unrecognizable outside our hospital. If you meet a colleague in a shopping mall, you may fail to recognize she is your friend from the hospital, because in hospital she looks different. Minimal jewelry, minimum ribbons. And these brilliant IT chaps will come to your hospital wearing lot of funky earrings with backflow hair. And you suddenly get dazzled that they must be bringing on the table something which is majestic, miraculous. Right? Now, they may bring any proposal, the world may put any intervention, any technology in our healthcare basket. The rule number one is to decide where it fits in. And in healthcare, it fits in into one of the four baskets. Does it fit in infrastructure? The building, the engineering, the automation of temperature control, the light management, etc., etc. Does it fit in, or even, for example, pneumatic chute system for blood samples, which is also a duct that goes through engineering services? Does it fit in into infrastructure? Two, does it fit in into medical technology? Laboratory, radiology, OT, sterilizer, gastroenterology, endoscopy. Because they can fit anywhere. It's a piece of cloth. You can stitch a shirt out of it. You can stitch a trouser out of it. You can stitch a coat out of it. AI is a piece of fabric. It's a data fabric. We can only touch and feel the fabric. What we stitch out of it depends upon our need. So we need to know the size of the person who needs to wear that dress, the likes and dislikes of his or her, whether it has to be a short one or a long one, depending upon the occasion. Just because fabric is good doesn't mean the dress would be good. And our job as healthcare providers is to convert the data fabric into data dressing. And therefore, the second vertical is technology. Does the AI algorithm, whatever it is, platform fits in into medical technology? The third vertical that we do a checkpoint is, does it fit into prescription management or patient care? Does it help me pick up wrongly delivered drugs? So for example, Buscopan, the medicine for cramps, which is supposed to loosen the stomach, and Bicasodil, the medicine given for constipation, for constipation, they both look alike. And Buscopan is supposed to loosen the stomach, and something else is supposed to tighten the stomach, or Loperamide. These are look-alike medicines. Does your prescription or the platform help you pick wrong prescriptions? Does your AI predict how many blood samples which were meant for biochemistry actually went to hematology? These are things that interface with prescription pattern in patient care. And the fourth is processes. Looking at the accident rate or the rate of entry into emergency services, can a model tell us what's the roster we should follow in emergency room? Is it true that in the month of January accidents are more, emergency admissions are more? Should we post more emergency nurses in ICU and emergency in January? Or in summer vacations? Or do we need to have more plastic surgeons during Diwali Pataka season? These are things that can be picked up because these are processes. And therefore, our rule number one for AI application in healthcare has always been check where it fits in. Does it fit in infrastructure? Does it fit in technology, medical technology? Does it fit into drug prescription and patient management, or does it fit into processes? Because those people who create platforms, they don't have this clarity. They come and share something useful, which is a brilliant piece of fabric, not a dress. What we need is a dress. Fabric is of no use. And that's our first checkpoint. The second checkpoint that we apply in our day-to-day work and at very, very large scale of almost 19,000 hospitals for an entire government, scale of almost 12,000 crore worth of medical products that we produce. The second checkpoint that we apply is, where does it belong to? What is the genesis of what is the intervention? And let me here tell you some simple definitions. Because when these things come to us, we don't know their origin. Broadly, any AI product in healthcare is derived out of three origins. First origin is database. That database could be yours, could be somebody else's. It's a simple database. You have 1,000 images of cataract. Your fundus camera takes one image, puts it into comparison with 1,000 image. If it matches, it tells you it is a cataract. If it doesn't, it tells you it is not. And while doing so, it has a percentage of accuracy, which by law has to be 96%, but it can range anywhere between 80% to 100%, depending upon the database. The second origin is if somebody has taken massive amounts of data and created an algorithm out of it. And an algorithm has a user interface which doesn't even tell you what it is, because it does what it has to do based on the codes that have been kept behind. And the third and the last thing which has emerged in last 2 or 3 years is large language models, LLMs, that none of us actually truly understand, because they are being built almost every day. Now, I will tell you something funny. Data has to be stored somewhere. In 2005, the power consumption per rack of data was 4 kilowatts. 4. In 2015, it was 20 kilowatts. And in 2025, today, it is 80 kilowatts. And that is why you had ChatGPT CEO mentioning on one of his blogs that the servers are smelting with heat. Because the speed at which data is being managed and the power which it consumes is so enormous that a data center, a simple data center could be easily 75 to 100 megawatts. When AI interventions are given to us to apply for healthcare, we don't know where they are getting stored. What is the speed of action? What is the speed of resultant supply of service to us? And therefore, the second checkpoint we do is to find out what is the origin of functioning of the intervention. Whether it is database, algorithm, large language model, who is storing, where is getting stored, and how it is getting managed. And chief information officers of your companies, your groups are more competent, but a bird's eye view for you is important. The third, and I'll stop with just 2 more, not to make it very complex right in the morning. Your application should define the product. Product doesn't define the application. If you, and I met a very senior kidney transplant surgeon who was with us at AMTZ, Dr. Raina from Mumbai, who almost does a couple of transplants every hour. That's his rate of kidney transplants. And there are huge amount of issues like neural pacemakers and many things that are coming. Pacemakers are also AI driven. So the latest pacemaker comes with a Bluetooth connectivity to your phone. It should come with a warning that phone should not be given to your wife, because pacemaker can literally stop your heart. And you have forgotten a set of things to do at home because of IPL is going on. It might be your last IPL. So these high-tech items now come with many interfaces. While defining these interfaces, what we do, And these are things that we do. By no means they are steps that what you should do. Maybe you should learn from what we do, improvise, change, delete, add, and do what you think is best for you. Now what we do is we categorize them into application as DX, RX, and PX. Anything that impacts my diagnostics is DX. It impacts diagnostics. Why it is different? Just yesterday, a patient with an extremely high D-dimer, and after COVID we all know what D-dimer means. D-dimer is an atom bomb sitting inside the body. It can explode any moment. A patient with high D-dimer, very, very high D-dimer, should be taken for angiography to look at cause of the clot and the placement of the clot quickly as possible. You delay it for 12 hours and patient is gone. But we generate tons and tons of pathology report every day. Can there be predictive steps to tell us which patients can actually go for the next level of intervention if something is wrong in the previous step? Now that's not happening, although it should happen by a simplest analyzer that you have. Most of you would have the standard biochemistry, hematology, electrolyte, blood gas analyzers right in your hospital. Most of you will have a laboratory management system right in your hospital. Most of you would have the laboratory management system storing data right in your hospital. It doesn't, but the predictability which is possible right in our own home is not getting done. It will take perhaps an hour for a good IT specialist to tell you what could be done with the existing resources, infrastructures, process and equipment and data that you have already in your hospital. It's possible. The second is RX, which is prescription. Large number of prescriptions that gets changed. That change is predictable. That change is predictable, correlated with the clinical investigation. And the third is PX, which is process. Many times in healthcare, we interchange the process. We send patient for biopsy first and mammography next. There are more than 70,000 biopsies for breast cancer that is done in India. And after 70,000 biopsy, mammography is done as if it is a fashion show. You go to a shopping mall, you try a shirt, you buy a shirt, but then you take another shirt, go to the dressing room and put it on the mirror. That second shirt in the mirror room is of no use. You have already purchased. If the biopsy has already told it is breast cancer, mammography is useless waste of money. There are 70,000 mammographies happening every month after biopsy. Processes. So the third checklist we do, and it might sound peculiar. So go ahead and check this out. It's an evidence right on ChatGPT. You can type it and see how many mammographies in India happen after biopsy, and our smiles will vanish. And therefore, the third checklist we do is to see whether intervention is impacting DX, diagnostics, RX, prescription, or PX process. And the fourth one, and that's where I close, having complicated it already too much. I come from a place in Vizag on the east coast. We are in Mumbai on the west coast. It's equally hot. We have everything of Mumbai except the traffic and the vada pav. Everything. It's just Mumbai. Many parts of Vizag actually look like Mumbai. But instead of vada pav, you have masala dosa. And instead of heavy traffic, you can reach anywhere in the city in half an hour. Now, as founder director of medical technology for Ministry of Health, when we were designing the National Radiology Program, National Dialysis Program, National Ambulance Program, National Teleradiology Program, and a whole lot of more than 27 national programs, and these are programs including diagnostics in PPP mode. We realize that 98% of medical technology in India is imported. You walk into a hospital, you only see foreign equipment. You can take a Vande Bharat train and it will be written local for vocal and made in India lion. But you cannot enter a hospital in which you can see written made in India hospital. You simply cannot. Because 98% of our hospitals use foreign medical equipment. Our import of foreign medical equipment even today is 64,000 crore per annum. That's what we import as a country every year. 64,000 crore per annum. Everything was imported. Therefore, in 2018, on 3rd of January, we started building a city in Vizag in a campus of about 8 kilometers. It was a jungle without a phone signal and a pin code. Today, in 6 years, we are world's largest medical technology cluster with 158 factories, 22 centers of Government of India, 7,000 people, with a World Trade Center and a WHO center. It's the only cluster in the world where we make from a mask to an MRI machine, CT scan to ventilators, anesthesia workstations to OT light, everything. And the same MRI machine that I was buying for 6 crore, I'm exporting at 2 crore 80 lakhs, 1.5 Tesla. At the peak of COVID, when India was using 12 lakh RT-PCR test kits every day, 12 lakh every day, 11 lakh every day was being supplied by us with 1,000 oxygen concentrators and 250 ventilators every day. So we are a place, and all of you are most cordially welcome, invited to come to AMTZ in Vizag. You can just type on ChatGPT, which is the most happening medical technology park in India, and you will get AMTZ as an answer. All of you are most invited. We are a place that produces everything in medtech. Now we are setting up Made in India hospitals, taking hospitals that are already existing, giving the entire range of medical equipment made in India, from a multi-parameter monitor to an MRI machine or a CT scan, at almost half the price. And we are setting up a center for healthcare computing, a healthcare quantum computing center. So those of you who are interested in being partners with us, in working with us to set up and manage the Healthcare Quantum Computing Center, please do write to us, please reach out to us. We would have lots to do together for you and for the country and for all the people around us. So thank you for giving me this opportunity, and we would be looking forward to having all of you with us at AMTZ. Thank you and Jai Hind.